P-glycoprotein is an efflux pumps which reduces the intracellular concentration of adriamycin. It was thought that, and suggested from many studies, that it reduce the response to chemotherapy. So it's associated with chemoresistance. Although not all the trials were consistent, and the technical to assess this expression varies a lot among studies. We included patients younger than 40 years and with localized high-grade classic osteosarcoma. So we excluded all secondary parostal or periosteal osteosarcoma. No prior surgery was allowed because this is a neo-adjuvant scheme. So all patients had the P-glycoprotein centrally assessed, and the P-glycoprotein negative received standard chemotherapy with MEP, Methotrexate, cisplatin, and adriamycin pre-op. After surgery, they received same drugs. In case of P-glycoprotein positivity, the treatment was different for according to grade of chemotherapy induces necrosis. Good response, the responders received the same drugs as P-glycoprotein negative, while poor responders receive one cycle of adriamycin postoperatively and 4 subsequent cycles of high-dose ifosfamide. Very similarly to Ramos, the treatment was adapted by chemo-induced necrosis. But the difference is that in this trial, mifamurtide, which is a macrophage, a specific stimulator, was used only in the subgroup of patient PGP positive. We included a total of 279 patients, and importantly, an amendment was necessary after 74 patients included because the results were below expectation. So the protocol at the end used 10 cycles of methotrexate, while at the beginning it was planned 6 cycles. Also, the same approach was adopted from the JACE group in 2013, which ran a parallel trial. The median age of the patient is 14 years, ranging from 4 to 40 years, and the P-glycoprotein was positive in the majority of the patients. The first endpoint was overall survival, and the 3-year overall survival was 85.3%. And the first unplanned result is the post-amendment survival reached almost 90 at 3 years, 89.9, as compared with only 78 for patients that received 6 cycles of methotrexate in the pre-amendment phase. So this confirmed that we were right. Methotrexate is important and the amendment was necessary. For event-free survival at 3 years, it was 65.5%. And again, there was a significant statistical difference after amendment. Secondary endpoint was also the survival according to PGP expression. And as for hypothesis, the P-glycoprotein positive had a better survival as compared with historical control. 70% event-free survival at 3 years as compared with 59.9% for PGP negative, meaning that this risk-adapted approach was able to rescue the high-risk patient. Also, the multivariate analysis confirmed that necrosis, phosphatase alkaline, and grade are important prognostic factor in localized high-grade osteosarcoma of the extremity. And the last analysis we performed, presented at ESMO, was event-free survival by necrosis and PGP expression. This subgroup analysis showed that the best survival was in PGP positive, good responders. So patient treated with MAP and mifamortide. So unlike the study by Mayer, which proved mifamortide active in association with ifosfamide, in the study we had also good results in association with MAP. The poor responder had an event-free survival of 60% in case of poor necrosis. So our conclusion is that in patients with non-metastatic osteosarcoma with overexpression of P-glycoprotein, the same probability of event-free survival can be achieved with the use of mifamortide combined with high dose of ifosfamide only in case of poor response. This strategy compares well with all prior studies in terms of event-free survival and overall survival. Pathologic response to MAP, as known, is the most strong prognostic factor for these patients. And we found out unexpectedly that the number of methotrexate cycles is fundamental in the treatment of osteosarcoma, and we suggest that it should be 10. And last, a pre-planned merge analysis with the Spanish sarcoma group is ongoing and will tell us more on a larger set of patients treated with the same approach. Also, we have a translational sample from about 85 patients, and we will perform nanostring to assess the role of tumor microenvironment in selected patient to seek a predictor of response.